Good afternoon. Today we will be discussing child-parent psychotherapy. This project was created by myself, Rafaela Rubalco, Brittany Marie Gonzalez, Isis Rivera, and Jaleesa McKenzie. So what is child-parent psychotherapy? Child-parent psychotherapy is an EBT. It is also called CPP. We will be referring it to that. And it's a method of therapy that aims to promote the relationship between a child and a parent for children who have experienced adversity or trauma in early life. So this can be any type of trauma or adversity, including emotional, physical, sexual abuse. It could be neglect. It could be a death of a parent, which is the most common trauma. So this therapy assists parents in understanding different developmental cues of children so parents can engage with the child appropriately. It promotes investigation and imagination in children so they can reach developmental milestones. It's centered around the idea that parents shape the child's view of the world. Anxiety is normal during these developmental stages. It enables children to problem solve to cope with this anxiety. Parental reaction to anxiety/fear and methods of parenting can conform anxiety in children. The origins of CPP. So child-parent psychotherapy was developed by Dr. Alicia Lieberman and Patricia Van Horn, who noticed that children experience domestic interpersonal trauma of violence or the loss of a loved one, and they really needed a therapy specifically designed for them, because there were no other therapies that specifically worked to address those issues and symptoms that they were facing. Driven by her personal experience as a child refugee in Nazi Germany and her extensive research on the effects of trauma on young children, Dr. Alicia Lieberman developed child-parent psychotherapy in the 1990s. She recognized that it was crucial to address the impact of trauma on both the child and the parent/caregiver, and emphasized the critical role of child-parent relationships in a child's recovery from trauma. As a result, CPP is a strengths-based, relationship-focused intervention designed to improve the relationship between parents and children, promote healthy attachment, and help children overcome the effects of trauma. The psychological history of CPP, it's actually based on attachment theory by Bowlby, where infants are predisposed to build attachment within the first year of life. Infants look to parents for comfort and for satisfaction of needs. This includes food, bathroom, social needs, things like that. When parents are when parents are unable to fulfill these needs, they're thus unable to provide feelings of protection for children. 3 aspects of social bonding. So there are 3 aspects. The first one is the formation and persistence of social ties in the infant under conditions of maltreatment. The second is the role of the attachment object in the adjustment of the infant to the broader environment. And the third is the infant's reaction to involuntary separation from the attachment object. The goals of CPP. So there are global goals that are established currently that are to be met with CPP. So this includes encouraging normal development and engagement with present activities and future goals, strengthening and supporting the child-parent relationship, maintaining regular levels of affective arousal, establishing trust in bodily sensations, achieving reciprocity in intimate relationships, resolution of trauma-related symptomology. And these are some trauma-related goals of CPP. Increased capacity to respond realistically to threat, differentiation between reliving and remembering, normalization of traumatic response, and placing the traumatic experience into perspective, as well as co-construction of a manually meaningful trauma narrative.
Good afternoon, class. My name is Jaleesa McKenzie. Thank you, Rafaela, for the introduction. During my portion of the video, I will be talking about the stages of CPP, what a session typically looks like, and the research associated with CPP. To begin, treatments last about a year and has 3 stages. Stage 1, establishment of partnership and devising intervention, which typically happens between the 1st and 3rd month. Stage 2, identifying points of entry and practice building on strategies. And stage 3, reinforcement of progression, which is typically in the last month. In stage 1, the therapist does this to observe and interact to identify strengths and opportunities, meaning figuring out how the parent talks to the child and ways that the child receives the message. Stage 2, identifying points of entry and practice building on strategy, which is between the 3rd and 5th month. During this stage, problem-solving strategies are figured out, and the therapist also figures out a way to help change the way the parent talks to the child or the way that the parent perceives the child. And in the last stage, reinforcement stage, they talk about issues that were had and things that could have been done better and things that work, preparing for termination. In the link included, it's of a father and a daughter receiving guidance from a therapist on how to maintain dialogue and participate in activities that interest his daughter. The therapist provides instruction through an earpiece. During the interview, the therapist promotes the father to use phrases like, "Good job," "I really like how you're playing with your dolls," and "Thank you for sitting next to me," to communicate with his daughter to encourage her to continue playing. The research associated with CPP. According to World Health Organizations, major depression. The research associated with CPP. According to World Health Organizations, major depressive disorders is ranked as the 3rd most debilitating disorder worldwide and the leading cause of disease-related disabilities among women. Although it has largely been through that mothers are at the greatest risk for depression during postpartum period, newer evidence suggests that the few years following childbirth may be comparably significant. Rich Edwards and Conan Woolhouse and colleagues found that almost 1 in 3 women reported depressive symptoms during the 4th year after birth of their child, with the prevalence of maternal depression. 14.5% at 4 years postpartum compared to 8.8% during pregnancy and 8.1% at 3 months postpartum.
Thank you, Jalissa. Hello, everyone. My name is Isis Rivera, and firstly, I'll be speaking with you today about what makes CPP an evidence-based treatment. Now, to jump right in, a study by Lieberman et al. 2005 was done with the purpose of assessing if PTSD symptoms were reduced in children who witnessed marital violence when treated utilizing CPP. The participants of this study included children 3 to 5 years old and mother-child dyads or pairing. So these 3 to 5-year-old children were given treatment along with their mothers. And during the study, the mothers mentioned that there were additional childhood stressors for the children, such as sexual abuse, community violence, and physical abuse. Child measures of PTSD symptoms included the children's exposure to community violence, parent report version, the semi-structured interview for diagnostic classification, and the child behavior checklist, which is a measure of stress-related behaviors, including but not limited to aggressive behavior, attention problems, somatic or bodily complaints, and rule-breaking behavior. Now, parent measures included life stressor checklist revised, the symptoms checklist 90, and the clinician-administered PTSD scale, which measured the frequency and intensity of re-experiencing avoidance and hyperarousal symptoms. Now, what was interesting about this study is that they included a comparison group, and the comparison group was treated utilizing case management plus individual psychotherapy for the mothers. And ultimately, the researchers found that the child CPP group showed a greater reduction in stress behaviors compared to the comparison group post-treatment, alongside that the mothers of the CPP group showed a reduction in avoidance symptoms compared to the comparison group. Now, it's important to note that both groups did decrease in symptoms for re-experiencing and hyperarousal. However, there was no significant differences in pre and post-treatment for the comparison group on the basis of avoidance symptoms. Additionally, no differences in symptom reduction were found on the basis of age. Now, an additional study by Hagen et al. 2017 was done to examine whether CPP was successful in reducing parent and child post-traumatic stress symptoms. Now, for the study, they treated parent-child dyads who had experienced interpersonal trauma. And some of the interpersonal traumas reported during the study were community violence, domestic violence, and a caregiver death. And the children in this study were aged between 2 and 6 years old. Now, child stress was measured utilizing the post-traumatic stress scale, which is derived from the traumatic symptoms checklist for young children. And parent stress was measured either utilizing the Davidson trauma scale or the post-traumatic stress scale interview. And symptoms measured during the study were related to hyperarousal, avoidance, and re-experiencing. And ultimately, the researchers found that parent and child PTSS symptoms were decreased after treatment, with child symptoms of arousal and re-experiencing decreasing at higher levels than avoidance symptoms. Now, decreases in parental stress symptoms were correlated with decreases in child hyperarousal and avoidance symptoms, and female children had the greatest improvement for the symptoms of re-experiencing and hyperarousal. Additionally, they found that greater reduction of symptoms was also found for families who reported fewer traumatic life events. Now, CPP is also strong in that it is culturally flexible. And the study by Norland 2021 utilized CPP in Sweden with the mothers and children who experienced IPV or interpersonal violence. And they found that the flexible design of CPP allowed for the adjustment of treatment. Now, the treatment was adjusted to factors such as parent schedules and the specific familial challenges. And what that means is that the researchers were able to provide the participants with treatment methods that were specific to them. So they were able to actually utilize treatment features such as in-person versus over-the-phone treatment with these parents. And ultimately, they found that this flexibility allowed for an increase in the effectiveness of treatment. Additionally, CPP is strong in how it strengthens the relationship between the parent and child. And the study by Guild et al. 2017 supports the statement that CPP promotes healthy attachments, as well as that it builds forms of effective communication used in layer relationships. And in that study by Guild, they reevaluate the attachment strength in children after CPP treatment. So once the children were the age of 9. And they found that attachment reorganization did occur, and that secure attachments were able to be developed in these children who had received CPP as part of their treatment plan. And ultimately, these children were rated as having better peer relationships and interpersonal skills in middle childhood than those with insecure attachments. Now, one of the limitations of CPP includes parental trauma and polyvictimization. And polyvictimization can make it difficult to treat parental symptoms due to difficulty in identifying the direct cause of symptoms or the direct trauma that may have led to specific symptoms and intensity and frequency. And the mother's over-identification of fear, anger, and stress in children as a result of trauma can further alter the parenting behaviors and child-parent relationships. Now, this is directly related to a second limitation in PPP, which is related to study methods. And most of the studies um, done surrounding PPP utilize parent reports of symptoms. Now, with that being said, it's difficult to obtain valid ratings of child symptoms without the parent input. Now, the study conducted by Hagen et al. Found that only 3 out of the 17 studies they assessed in their literature review use an external reporter, such as a school teacher or a counselor. So they theorized that it's possible that more symptomatic parents also rated their children as more symptomatic. And the last limitation of CPP I want to speak to you about today is in regards to the parental relationship. And CPP would not be appropriate for children who have developed trauma or stress symptoms as a result of abuse from a parent. More specifically, it would not be appropriate for the parent who conducted the abuse to be present with the child in treatment. And the study conducted by Bernstein 2019 mentions that the participants of that study were referred to by family court, domestic violence service providers, preschools, and child protective services, among other organizations and institutions, and that mothers were excluded from their study if they were currently homeless, experiencing substance abuse, if there was documented child abuse by the mother, if the perpetrator was living in the household at the time of treatment, or if the mother was experiencing psychosis. Now, ultimately, if the child is placed in treatment with their abuser, this could lead to further psychological, emotional, and physical harm, and ultimately increase stress symptoms for the child. Now I'll be passing the mic along to my colleague, Brittany, who will be speaking to you a little bit more about CPP research and more specifics on why it is useful. Thank you.
Hey everyone, I'm Brittany, and I'll be here to explain to you why do therapists rely on CPP and so much more. Now, as you guys are already familiar with and understand, child-parent psychotherapy is a relational treatment for children in the age of birth, all the way into like 5 years age range. And they are specifically for kids who are showing mental health or mental illness or behavioral disturbances or are at risk for these difficulties. As a result of exposure to traumatic events, environments, and adversities, parental mental illness, and or harmful parenting practices. It is significant to highlight that therapists must rely on CPP as it is the best method of treatment for children and parents that have struggled with adversities and require treatment. As this therapy is based on attachment model, it is attachment model created by Bowlby. It also allows for great insight into what children and parents may be experiencing, such as a strained social bond. Child-parent therapy is built on a psychodynamic model that capitalizes on cultivating a strong relationship between the therapist and the caregiver to model reflective and sensitive caregiving behavior, and also provide a corrective emotional experience because this approach is supportive and non-dyadic. That's mainly why a lot of therapists do rely on CPP, especially with mothers, as research has been showing, especially with mothers who suffer from postpartum or depression. It is significant to highlight that and understand that this is not your average therapy. This is not where you go and you have you're forced to speak to your child and you're forced to like men things. No, this is a therapy where you guys are creating a social bond that is already tainted in a way, which is why research shows that mothers who suffer from depression or postpartum, a lot of those mothers, some mothers don't feel a connection to their child, especially after they just have given birth to them. Many do have that attachment, and they do have that love and attachment already there and that bond. But the ones that don't, it's okay, because we have something for you: child parent psychotherapy. This is very important because in this core treatment, like introducing the child to CPP, it can be very overwhelming. But the first joint session with the parent and a child recapitulates the treatment plan, which is your goal. There is an end goal of CPP, but it's also a treatment plan that it's agreed on during sessions. The therapist and parent jointly introduces the formulation triangle to the child, using words and actions that are geared to the developmental stage. As you can see in my next slide, it does show how the goals of CPP is functioning, emotions, and it's functioning, behavior, and feelings. I said emotions, I meant feelings. The treatment plan is also about experience. Many people who do go to CPP, they have been exposed to traumatic events, which has maybe caused that disruption in that bond. As I mentioned prior, the goal of CPP is all about experience, functioning, behavior, and feelings. With that comes treatment. The treatment goal is to help parents create physical and emotional safety for the child and the family by promoting an age-appropriate partnership between the parent and the child. So, as I said, going back to referring earlier, as I said, this is not your regular typical therapy. This is a therapy that's mending two people together. It's not like couples therapy neither, because you don't have playtime in couples therapy. Like they incorporate so many different ideas into this therapy that allows the child to flow and move freely, as well as also getting treatment. So it is definitely something that is very different. Future research also shows that it can be questionable sometimes. And I say that to say because they question whether the resource and intensive of nature of CPP may create barriers to accessibilities and scalability. Furthermore, such a time-intensive intervention incurs ongoing costs when limiting the number of families that clinics and clinicians can serve. So with that being said, it is important to understand that with treatment comes a lot of hard work and also commitment and consistency. It goes hand in hand all together, because it is important to highlight when you are getting treatment, you want to be consistent with it, because remember, the child can easily detach at any moment if the bond is not fully there. But not to get all sidetracked, there has also been future research identifying behavior mechanisms of change. And it is important for future research to identify intervention modalities associated with change, because with this treatment comes change. And for example, CPP's intervention modalities include 1. Promoting developmental has affected this bond. This secures a bond as time goes and as treatment progresses. Going back to this, I said that 1. Promoting developmental progress through play. I forgot to say physical contact and language. It is very significant to highlight that. 2. Offering unstructured reflective developmental guidance. And 3. Modeling appropriate protective behavior, because we all know that children who have ACEs, they need protective factors in their life, and protective factors can also go hand in hand with protective behaviors. That is very significant to a child's development, and that can be crucial if tainted with. For interpreting feelings and actions, because it is important to listen and interact with your child. And 5, providing emotional support and empathetic communication. As I said, mothers who suffer from postpartum. There have been many research where mothers who suffer from postpartum are reliant on child-parent psychotherapy, and this is because of that right there. The emotional support it provides and the empathetic communication that is also served along with CPP. It is very significant because a lot of mothers who experience postpartum or depression, they are kind of trapped in their own mind. They're learning about their new selves, and it is very hard when you give birth and it feels like, not that you don't want the child, but you don't have that attachment there. And that's very significant. That attachment is going to be very significant throughout not only your life, but the child's life as well, and the child's development, because it has everything to do with one another. And last but not least, it also provides a crisis intervention, case management, and concrete assistance with problems of living. Because as we all know, regular therapy, you can go to your therapist and trauma dump or unload and really just let it all out there. Here, it's like that, but you're also getting the treatment, which is as far as what your end goal is, as far as attachment, as far as whatever it is you desire with your child. Treatment considerations are truly really important. The children's developmental stage is also very crucial, as I stated earlier. Within the goal of CPP, the clinical case formulation takes into account the young child's developmental stage. Babies are clearly not in a position to understand a verbal explanation of the triangle figure that I showed you guys earlier, which is on the slide of the goal of CPP. So, their treatment involves helping the parent to learn to read and respond to the child's affective signals and exploring the emotional obstacles that the parent may encounter in this process. Beyond infancy, even barely, verbal toddlers can be remarkably responsive to a brief explanation of what happened to them, and are able to use simple words to describe how sad and mad they can be, and can show how they feel about what happened. But when a toddler or preschooler is able to use language and symbolic play to describe experience and articulate feelings, the treatment focus shifts to make the child an active participant in the treatment. And this is why I said this is a dual treatment, because not only is it just the parent, it's also the child interacting with each other. So not only, I named all the benefits of it and why therapists rely on it, and I love it. I actually sat down on a CPP therapy with someone a therapist I'm interning with, and it was very significant to highlight how it was a 4-year-old boy who saw his mom get murdered by his father. And it was very significant to see the child during playtime interact with his toys and his language he used. It was very detrimental to me because I'm so empathetic, and I don't know how to separate that. But I can only imagine how detrimental it was to him. He explained he used some sort of something similar to a truck, and in this truck he had like used two trucks and said like, this is what my mommy did to my daddy. And he showed me, he showed us what he experienced. And it was very important that to understand the CPP developmental framework that incorporates the developmental anxieties. I mean, it's elaborated more recently, by Marins, and just it's just important that fear of separation and loss, fear of losing a parent's love, and fear of body damage, fear of moral condemnation, and not living up to the expectations of one social group. Once established, these fears last throughout the life, of course, and may re-emerge when the adult is feeling vulnerable because of the internal and external circumstances, which is in situations such as trauma and adversity. As I mentioned previously, reality serves as a confirmation of the child's normative fears. Many children are abandoned and insufficiently loved, honestly, physically harmed, and told that they're bad, when truly they're not. They're really not. Like, I don't know, but I know, if that makes sense. Like, we are product of our environments, but this treatment is deemed very successful. And when I say very successful, I mean a lot of parents choose child-parent psychotherapy because the child's reliable protectors, because the parents want to become the child's reliable protectors and consistently guide the children or child towards the three key components of early mental health, which is developmentally expectable, affect regulation, safe and satisfying relationships, and pleasurable engagement and exploration and learning. It is very important to understand that. But this is deemed as successful, and I hope you guys enjoyed our presentation. Thank you so much for listening.